The background of the study was that kidney cancer accounts for 5% and 3% of all cancers in men and women, respectively, and approximately 20% of these are metastatic at diagnosis. For the past 20 years, the standard of care for these patients had been surgery and systemic therapy. At this time, it was the cytokines and interferon. But since 2005, with the advent of targeted therapies, the standard of care has changed, and treatment became nephrectomy plus sunitinib. However, the role of nephrectomy in this era of targeted therapy is in question and has been addressed by multiple retrospective studies. So we try to design a study to know if it is still necessary to operate these patients with synchronous metastatic kidney cancer. So let me take a few seconds to explain the clinical situations that we typically have. Number one, patients with kidney cancer, good performance status, and small metastatic tumor burden, like, for example, small lung mets. And for this patient, nephrectomy is certainly useful, and treatment is commonly delayed. The second situation is patients with kidney cancer, bad performance status, and a high volume disease. And for these patients, unfortunately, nephrectomy is not useful, and systematic treatment has to be started quickly. And patients with kidney cancer, performance status 0 or 1, limited metastatic tumor burden, who knows if nephrectomy is necessary? Carmela was exactly designed for these patients to test the benefit of initial nephrectomy against the benefit provided by targeted therapy alone. So Carmela was a big study, 450 patients, 79 centers from France, the UK, and Norway. Inclusion time was over 8 years, between 2009 and 2017, and with the multidisciplinary approach, including urologists and medical oncologists. So the design of the study was to include 450 patients with clear cell mRCC confirmed by biopsy, documented metastatic disease, patients were 0 or 1 performance status, amenable to surgery, and eligible for sunitinib. Patients were stratified according to the MSKCC's classification in 2 groups, intermediate and poor risk groups. The question is why there is no good prognosis factors for these patients. It is because, by definition, these patients were excluded from the good performance status because they have synchronous metastatic kidney cancer. Patients were randomized 1:1 between the arm A, the standard of care, 226 patients. We have a nephrectomy and sunitinib, and the experimental arm, which included 224 patients. The primary endpoint was the overall survival, and secondary endpoints were PFS, the tumor response, the clinical benefit, and safety. This is the results of the primary endpoint. The Kaplan-Meier curves indicated the percentage of patients who are alive at 1, 2, and 3 years according to the treatment in red, sunitinib alone, and in blue, patients with nephrectomy plus sunitinib. Median overall survival was higher in arm B, sunitinib alone, than arm A, 18.4 months versus 13.9 months, with a median follow-up of 50.9 months. The non-inferiority condition was met with an hazard ratio of 0.89, and the confidence interval was superior to 1.20. Conclusion: sunitinib alone is not inferior to nephrectomy followed by sunitinib. Carmela was a non-inferiority study. Non-inferiority for OS was demonstrated in patients with both intermediate risk and poor risk group. PFS and clinical benefit were greater with sunitinib alone compared with nephrectomy, and we propose that when medical treatment is required, sector-reductive nephrectomy should no longer be considered the standard of care for these patients with synchronous metastatic RCC. All the results and data will be published tonight in the New England Journal of Medicine. Thank you.